So this week's Ask the Doc question was one that comes up for Jim and I in practice quite a bit is, Doc, do I need an MRI? Do I need an X-ray? And this is an interesting topic because I think the answer to that lies, let's roll with X-ray first. I believe that the answer to that one lies with which doctor are we talking about? And in our case, as being a chiropractor who's going to work with the spine, there are times where if we don't know exactly what's going on in there that we could find on an X-ray, we could be doing more harm than good. And,
Right. Yeah.
and while we can do a lot via examination, some of those things that could come up on an X-ray, we're not going to necessarily always be able to pick up on.
So I think you'd said something off air that I feel like summarizes a lot of this. Is it going to determine or change what we might be doing to help treat that patient or get them better? Sometimes I'll go through a couple sessions and see if what I'm doing is helping, and then you kind of just know if are we getting anywhere or not, and then we'll order that next image. But if the person ends up getting better, then maybe we didn't need to order it. But if someone's curious about, hey, what's my spinal health looking like at age 25, 30, 35. Some people are really analytical and they want to kind of see just like the smile on their teeth. They're like, am I holding a good, correct posture? Are the discs looking beautiful? And that's the rarity. But there are people now that are starting to take more, action and seeing themselves look beautiful on an X-ray, not just a smile on a face.
Yeah, I know Deed Harrison, who's kind of the founder, his father was, but he's kind of rolling with the chiropractic biophysics protocols that are so popular right now, and they focus so much on making sure that your postural curves are correct. In a technique like that, whatever you find on that X-ray is absolutely going to change the way you treat the patient, so therefore it's extremely important. And people will say, well, where's the research? Deed Harrison has research out the wazoo that shows the importance of the curves in the spine and how its relationship to general biomechanics and in health, how they play into a daily activity role. I don't really understand the question of where's the research, and I think it's as with anything, if you're not Deed Harrison, you're going to try to pick on it, and I think that insurance companies start to question, well, what's the necessity of it, and then they're saying, well, do we really need the radiation? I mean, let's be honest, we get more radiation from our new 5G phones than we are from a couple plain film X-rays. And I think the next question is, if you're getting them from a medical doctor, how many times do we see an X-ray report coming from a medical doctor and the X-ray report says no significant findings?
Right.
We look at it and we're like, what do you mean no significant findings? The biomechanical implications of what we're seeing on the film are huge, and they could be affecting you on a daily basis.
And I'll always ask for a copy of the X-rays. Nowadays, they burn them on a disc. For maybe 5, 10, 15 years ago, they were an actual physical X-ray that you'd have to go get copies of. But I'll always look at them and sit down and explain to the patient, I know your doctor said you look fine, but that's how they're looking at it through our eyes as a chiropractor and a biomechanic expert. We want to see, how's the spine looking here, because we know what the spine looks like if it has good outcomes for longevity, or, hey, we need to fix something now. And that way, in 10, 15, 20 years, this X-ray keeps looking as good as this or better, not looking worse.
Right. And we're looking at it from not just a pathological standpoint. And that's nothing against the radiologists that are out there, but they're looking at it simply from a pathological standpoint. They really barely touch on here and there. They'll touch on a biomechanic aspect if there's a curvature or something that's super obvious. And to that standpoint, we like to see our X-rays from a upright position. So when
sitting or standing versus lying down.
Yeah, if you're taking these lumbar spine X-rays and the patient's laying, you're not really getting any biomechanical information because people don't have a lot of pain when they lay down. Typically, they're having it when they're sitting or standing.
And the curves change.
Correct.
So if you guys ever look at your X-rays, or if somebody sits you down and you're looking for the curves of the spine, but they were laying down, they'll call them recumbent X-rays. The curve may be completely different lying down versus standing. And to Craig and I, and to any other chiropractor, we want to see what you look like standing, because that's what you're doing, and that's usually when you feel your pain, is when you're up moving around.
We always talk about how important gravity is to your spine, and the fact that if we could magically shut gravity off, we'd be out of a job. But gravity is real, and it seems to work every single day, no matter what we do. So we need to see those films realistically with gravity and see what type of changes are happening with that. Moving into the MRI world. So the MRI is a little bit different because MRIs predominantly are done laying down, we're not getting nearly the amount of biomechanical information. And I know they do have some simulated weight-bearing MRIs. We don't find a lot of changes with that. I think maybe for a while I was ordering simulated weight-bearing and regular MRIs, and I think I found one or two differences as far as like how much a disc looked bulged or protruded or whatever. But for the most part, the sitting versus standing on MRI is not as important. We're looking for soft tissue stuff in the MRI, and ultimately it comes down to expense of the test here.
Real quick, so the soft tissue, tendons, cartilage, ligaments,
Correct.
just for those who
and,
don't know.
and discs.
Yes, and discs.
So in the MRI world, we're looking at those predominantly, and some of the deeper aspects of the bone that maybe an X-ray isn't going to necessarily show. You can see different water and fat components inside of a bone or inside of a soft tissue. You can see that on an MRI where we can't see that in an X-ray necessarily. So that's kind of what we're looking for there. But what dictates ordering that, and here's where I think we have to switch gears a little bit and maybe we change our stance. What dictates ordering an MRI is what type of symptoms are you having? And in our world, predominantly, the one main thing that we're seeing to dictate whether or not we're going to order that is radicular symptoms that are not being relieved through our conservative care that we offer. And we usually have a time frame, and we'll give somebody maybe up to 6 weeks, provided they're not getting worse, but maybe up to 6 weeks of conservative care and see if that stuff is improving. If it's not improving at that time, then we're going to be looking at the MRI. Now, again, a couple exceptions to that. If we're getting changes in our bowel or bladder habits, or we're getting, here's the key word, progressive neurologic deficit. So we're getting more and more numb. We're having less and less ability to contract the muscle. We're having more and more trouble putting weight on a leg or whatever it may be, or we can't feel our arms, we're dropping things out of our hands. Those things, if they're getting worse, we need to order that sooner rather than later because of the damage that could be done for more of a long-term basis. Now, why don't we order an MRI right off the bat? The reason is there's tons of false positives on MRIs. Mm-hmm. And we can find up to 80% of the population that's asymptomatic and they have a disc herniation or bulge on MRI findings.
And asymptomatic, for those who don't know, that's no pain. So imagine you having no pain, and then you go in for an MRI, and you're seeing that you have one or multiple levels of a disc bulge. It's fascinating. And then you take someone else who has extreme 10 out of 10 pain, radicular symptoms, and they take an MRI, and maybe they can't find anything that you would normally think would be obvious on film. So it's a good test. It's not something that you're going to base all of your treatment off of, because if you have someone coming in with what you described earlier, something radicular, so like pain going down the legs or the arms, numbness, tingling going down the legs or the arms, and then you go and take this expensive test and you don't find anything, now what? Then you have your orthopedic testing that hopefully you'll fall back on, or other things that you'll do in the office. But is the test going to change your treatment plan? That's why this always comes back to us having this controversial conversation. Do we actually need it, and when is the correct time for an MRI?
Yeah, and with going back to some of those stats, just we looked at in the one study, it was like a meta-analysis, and they looked at like over 3,000 patients, and that met this. They said the prevalence of disc degeneration, and they studied people at 80 years old and at 20 years old. The prevalence of disc degeneration in asymptomatic, again, no pain individual, at 20 years old, 37% of those people had some level of disc degeneration. And in the 80-year-olds, it was 96%. So that's a pretty, I don't want to say it's normal with age, but at the same time, that's kind of maybe the least concerning thing is just degenerative change in the disc. And then the bulge, the prevalence was 30% of 20-year-olds and 84% of 80-year-olds. Again, is bulging that important? This study would kind of tell us maybe it's not super important. Moving down now, a disc protrusion, which is a type of herniation, and I'm not going to get into all the specifics. I might throw a graphic up, but we can maybe even just do the whole disc herniation versus protrusion versus sequestration and extrusion and all those stuff. Maybe we'll do that for another topic. But the protrusion prevalence increased from 29% of 20-year-olds had one, 43% of 80-year-olds had one. So that maybe is a little bit more significant of a finding because it doesn't change nearly as much with age. So it's not necessarily an age-related finding. However, still looking at that, 29% of people with no pain had a disc protrusion. Now, let's say that person rolls in to medical doctor, not picking on medical doctors, but rolls into medical doctor who says, you have this particular type of pain, and he would totally skip out on the orthopedic test and maybe doesn't send to chiropractic or physical therapy or whatever. He says, let's order an MRI day one. You look at that, and that person has a disc herniation. They say, well, let's go in and get the surgery. If the surgery didn't help, why is that possible? Because you've got 30% of the people at 20 years old that have this thing and they didn't even have any pain. So it's not always an indication of, here's my problem.
And they totally miss it. And then there's, like you just said, an unnecessary surgery, or, you get around the ringer, and then now you have a permanent scar in that area, which now in 10 years is going to cause pain. And then you're in this. Yeah. And so you just want to really be careful, guys. Like, make sure have a good relationship with your doctor, have a good relationship with your chiropractor, make sure that you know what you're getting into before you start ordering some of these tests, and understand, like, what are we doing if we find A, B, or C on the film, or if we don't find A, B, or C on the imaging, and always have, make sure, like, you question, like, you guys are tuning into this. Hopefully you are interested or curious, or you have had chiropractic experience before, but wheel it back to your medical doctor and ask them, like, what are your thoughts about me seeing a chiropractor first? Because a lot of times, like you said, they will skip chiro and go to PT because it's more of a hospital-based type relationship. But it's rare for them to be like, yep, go see a chiropractor, because they think kind of what they learned in school is that, we're all quacks and they're aggressive and you're going to get worse. And it couldn't be further from the truth.
No. And
these are what we are fixing in the office. We are the correct referral. If medical doctors who are watching this don't know, start to go meet your local chiros and find out if they specialize on disc issues or radicular issues, because this is what you and I are fixing on the daily.
And please don't think that this is a knock on physical therapy. Both Jim and myself do a lot of exercise-based treatment in the office, and we have no problem whatsoever referring out to physical therapy because, I don't have all the machines that everybody has, and sometimes I just don't even have the availability to see somebody multiple times a week. If somebody's non-compliant with their home exercises, then they need to be in a physical therapy office. But we're going to be able to tell the right timing for that. I liken the strengthening part before the correction part to fixing the sheet metal on a car without straightening the frame. And that doesn't make a lot of sense. You wouldn't do that in a car accident. So why would you do that, to your body? So, that's not to say that every physical therapy modality is based upon strengthening, but a lot of it is. A lot of it is.
I don't have a problem referring out. In fact, I do that more than probably anybody, but I feel like I have a problem when we are overlooked as a profession, because if we all worked together, the patient would get better so much quicker.
Absolutely.
And, I know when to send out to PT. I have a really, a good handful of massage folks out, because I don't have anybody in my office, but you have some that you're lucky to have within your office. And then we have a list of people that we know who to refer out to for that specific surgeon or what have you. So, I just wanted to specify, we love making sure that we know how to bridge the gap between the different professions, but it's tough when you're the profession that gets overlooked, and we could be the keystone to the whole picture.
Yeah. Yep. All right, we're going to take a real quick break, and then what we're going to do, we're going to come back with our final thoughts, and be right back.